Hello, welcome to the program, Evolving Role of Venous Stents and How New Data Will Affect the Clinical Landscape. I'm Raghu Kalluri. I'll be your moderator. I am the Assistant Medical Director of Vascular Medicine and Vascular Labs at Ohio Health, Columbus, Ohio. I am joined by my esteemed colleagues, Stephen Black. Mr. Black is a consultant vascular surgeon at Guy's and St. Thomas in London. Kush Desai, Dr. Desai is an associate professor of radiology at Northwestern University Feinberg School of Medicine in Chicago. Aaron Murphy, Dr. Murphy is the director of Venous and Lymphatic Institute at the Sanger Heart and Vascular in Charlotte, North Carolina. This program is approved for 1 hour CME, CNE, AAPA, and AART credit. The CMEs are provided by the North American Center for Continuing Medical Education, LLC, an HMP company, and the program is supported by an educational grant from Medtronic. So my goal today is to talk about entire spectrum of venous disease as a disease state, and also talk about some of the data and new guidelines that are available for practitioners who practice venous disease. As most of us know, the symptoms of venous disease, also called as the hasty symptoms, heaviness, achiness, swelling, throbbing, and itching, are a function of the underlying venous hypertension, which is either from underlying venous obstruction or reflux, or a combination thereof. Obstruction is generally in the iliocaval system, but sometimes you'll see that in the femoropopliteal system as well. And reflux is anything below the level of the inguinal ligament, whether it's superficial veins, perforators, or deep venous system. Within the last few weeks, revision of the CEAP class has been published in the Journal of Vascular Surgery, Lymphatic and Venous Disease, and it's important to understand the new changes. As most of us know, CEAP classification classifies the venous disease presentation from C0 to C6, C0 being no venous disease and C6 being active ulceration. And there are multiple levels with the presence of varicosities, presence of edema, lipodermatosclerosis, skin changes, and venous ulcers that go through C1 through C6. Now, the new additions to this classification system is the presence of recurrent varicose veins, referred to as C2R, and corona phlebitica has been added to C4C. A recurrent venous ulceration has been added as C6R. Important to remember. So when you look at the presentation of venous disease in its chronic form, it presents itself either in the form of varicosities in the great saphenous distribution, small saphenous distribution, anterior accessory great saphenous distribution, or posterior accessory great saphenous distribution, or in the non-saphenous distribution, such as the mid-inguinal ligament here, or the posterior buttock area down into the thighs. And typically this is associated with a pelvic issue such as iliac vein obstruction or gonadal vein reflux, which we'll talk about in a bit. Other than the varicosities, the skin changes such as profound eczema, venous ulcerations are also seen in chronic venous disease forms, whether it is from superficial venous disease or from deep venous disease related to post-thrombotic syndrome. In its acute form, venous disease could be either asymptomatic with asymptomatic DVTs, or extremely enlarged leg with massive edema from the thigh on down to the ankles in the setting of phlegmasia or near phlegmasia. We also need to understand that there are compression points, and most of us know this about the iliac vein obstruction syndrome, which is usually in the left common iliac vein by the compression of the right common iliac artery. But similar compression can happen in the right common iliac vein, left common iliac vein at the confluence of the internal iliac artery, bilateral common femoral veins by the profunda arteries. Again, when you're examining the patient, it's important not just to look at the legs, it is also important to look at the abdominal veins. This is a paper published again in Journal of Vascular Surgery, and the presence of mere varicosities on the abdominal wall, also known as collaterals, has a specificity of 86% and a positive predictive value of 93% in diagnosing iliocaval obstruction in these patients. So simple examination of our abdomen is also important. So let's talk a little bit about arteries and veins. In the setting of obstruction, the high pressure velocity coming down hill is going against the peripheral resistance. On the flip side, if there is an obstruction in the vein, low pressure and low velocity flow is coming toward the obstruction upstream. But beyond that, closer to the heart is the low resistance in the right atrium. So apart from the blood flowing in these conduits being similar, everything else is different, including the compliance. Important to remember for folks who are starting out in venous disease. When you look at the presentation of venous disease and arterial disease, however, similar to the CEAP classification we talked about, which has C1, C0 through C6, Rutherford also is graded from C0 through C6. While the earlier forms have some similarity, the later forms actually have a significant amount of similarity with patients with significant discomfort from C4 through C5, similar to the Rutherford 4 and 5, and then venous ulcerations similar to the gangrene, although PAD is quite limb-threatening than venous disease. So when you look at CLI compared to the severe form of venous disease, that is venous ulceration, clearly, as I said, CLI does have significantly high mortality. The amputation risk with CLI is also a major problem, while it is incredibly rare with venous disease. But if you see enough patients, you will see amputations even in venous disease. Here is an example of a patient with phlebo lymphedema with above knee amputation from severe cellulitis and gangrene. Venous ulcers approximately account to 70% of all lower extremity venous ulcerations, with a prevalence up to 600,000 annually. And about a third of these patients will experience 4 or more episodes of recurrences. When you look at the cost, CLI does cost a significant burden on the healthcare expenditure, up to $20,000 per patient as calculated in 2011. We have found that VLU, venous leg ulcerations, cost significant amount of burden, economic burden on the society, up to $3 billion in the United States. There are significant disparities in CLI care, whether it's regional, whether it's amputation related, whether it's gender or race. Similarly, there are disparities with venous ulcer care as well, with higher prevalence of these ulcerations in lower socioeconomic strata and fewer years of education. Similar to CLI, pain and quality of life are known to be worse in women compared to men, but rest, such as regional disparities and race disparities, are unknown in terms of venous leg ulcers. Critical limb ischemia is a complex team sport. You need a whole lot of different specialists and a whole lot of different aspects of CLI being treated, such as infection control to revascularization. But when you look closely, venous leg ulcerations are not that different. Perhaps instead of diabetes management and minor amputations, you might need to treat obstructive sleep apnea and associated lymphedema. Instead of revascularization, you might want to treat superficial venous reflux. And for advanced reconstructive surgeries, you might want to replace it with deep venous treatment, such as stenting, etc. So ultimately, there are similarities between severe arterial disease and venous disease in multiple aspects. So let's talk a bit about the treatment options for superficial venous disease. We all know that the axial treatment of superficial venous disease is with thermal ablations and non-thermal technologies. The goals of management of superficial venous disease should include understanding the pattern of reflux, whether the segments involved include the perforators and deep veins, whether there is involvement of pelvic component, as I said earlier in my talk, and also to set those expectations right and patients understand that we're treating what is at hand at any given time, and there might be recurrences in the varicosities and the treatment and the symptoms associated with them. The treatments, as I said, axial vein treatments are thermal and non-thermal ablations, while non-saphenous treatments include phlebectomy, foam sclerotherapy, and foam sclerotherapy assisted phlebectomy. Sclerotherapy could be done in multiple forms, such as foam, liquid, visual, and ultrasound-guided treatments. The new appropriateness guidelines criteria coming from American Venous Forum also was published within the last few weeks. And if you look at the summary, the ablation of great saphenous vein in symptomatic patients, both with axial reflux and without saphenofemoral, with or without saphenofemoral junction, is deemed appropriate. In patients who are symptomatic between classes of C4 through C6, if they don't have above the knee reflux and they just demonstrate below the knee reflux, that is also deemed appropriate with certain caveats. And ablation of below knee great saphenous vein in patients just with edema may be appropriate after a wide range of coexisting non-venous causes of edema are excluded, such as central venous hypertension, obesity, calf pump dysfunction, etc., since these legs are connected to the heart, the pump, the main pump in the body. Here is a study where we found that in patients presenting to our institution with chronic venous disease, a fourth of them had central venous pressure elevation, and another fourth had documented obstructive sleep apnea. So this is important to understand and look at the picture and the patient in the big picture and not just for venous disease. Let's talk a bit about iliofemoral DVT management and just talk about the randomized controlled trials. The CAVENT study and the ATTRACT study come to mind. As all of us know, neither of these two studies met their endpoint in showing any significant difference in post-thrombotic syndrome, but there certainly is a signal in the iliofemoral DVTs that catheter-based techniques, whether it's lysis or thrombectomy and stenting, helps in these patients. Let's move on to the severe disease and talk a bit about surface veins. Another landmark study is the EVRA study, which randomized treatment of superficial veins earlier compared to a differed treatment arm. The earlier intervention demonstrated faster healing time, more ulcers healed at 24 weeks, and more ulcer-free days within the first year. But EVRA did have some limitations, as most people have pointed out on the podium at various meetings. The biggest of these include the number of people screened. 6,555 patients were screened, and only about 450 patients were enrolled. 1,700 plus patients were excluded because the ulcer age was greater than 6 months. As you can see here, the median size of the ulcer was 2.4 in the early intervention and 2.9 in the deferred intervention. So these are relatively small venous ulcers, and as folks who manage venous ulcers know that some of the venous ulcerations that are lasting longer than 6 months could be much larger. So we don't know what happened to the recurrence rates of those particular ulcers, what the prevalence of deep venous obstruction in those excluded patients were, and how those patients fared in this trial, if they followed at all as a registry arm. So that's that needs to be seen and better understood. One of the newer papers, again, that came out only within the last few weeks is from Peter Lorenz and his colleagues, who looked at 832 ulcers and looked at compression versus superficial venous interventions, or compression versus deep venous stenting. And we'll concentrate for the purpose of this talk, since we already have the superficial venous evidence from EVRA. When you look at the deep venous stenting patients of this stenting cohort of 95 patients, it is kind of interesting to note that conservative management at 36 months led to approximately 49% improvement or healing in the ulcers, while iliocaval stenting alone resulted in 77% of healing at 36 months, and incremental approximately 28% healing. Now, when you add ablation to it, and incompetent perforator ablation and incompetent great saphenous vein ablations, these rates increased up to 87 and 91% in these patients at 36 months. So this incremental improvement of ulcer healing is demonstrated for the first time in this study, and it's important to remember. The appropriateness use criteria published by AVF specifically assessed the iliac vein stenting in the presence of superficial venous disease and absence of superficial venous disease. And when you look at these guidelines, the iliac vein or IVC stenting for obstructive disease without superficial venous reflux as a first-line treatment is considered appropriate, but iliac vein stenting for obstructive disease with or without superficial venous disease in classes C3 and below may be appropriate, but again, care needs to be taken to make sure that there are no other concomitant disease states that can result in edema, etc. It is never appropriate to stent incidental May-Thurner compression in the presence of minimal symptoms, according to these guidelines. So again, to summarize, stenting without superficial venous reflux in patients with C4 through C6 is considered to be appropriate. Ultimately, again, as I mentioned, we have to treat the patient as a whole and not just the veins. We talked about elevated central venous pressure, we talked about obesity, we talked about calf bone dysfunction, but there are still lots of areas that are poorly studied, or the efficacy is inconsistent. For example, in lifestyle-related issues such as avoiding trauma, elevation of the legs, exercise therapy, weight loss, smoking cessation, not much studied at all. Compression stockings is studied, but there are differing opinions in that. Edema pumps, such as vein pumps and lymphedema pumps, the evidence is only now coming out. There is not much data out there regarding professional ulcer care or wearable devices. In terms of efficacy being inconsistent, not much is known about the anticoagulants, nonsteroidals, other medications such as pentoxifenolin and venoactive drugs. And we still don't know what the effect of surgical aspects of venous disease, such as debridement, skin grafts, endovenectomy, and bypass surgery for veins and valvuloplasty. So a lot more to learn. That is a whirlwind of venous disease in its acute and chronic form. At this time, I would like to invite my colleague, Dr. Stephen Black. Thank you.
So I'm going to present on the ABRE study 12-month results, which, as you may know, were presented for the first time at the Charing Cross Symposium this year. It's a great honor to present this on behalf of Erin, who's of course on the call, and myself and the other investigators involved in this study. The ABRE study was a pivotal IDE study of 200 patients recruited from 24 sites, both the US and European sites. And as mentioned, was principal investigators were myself and Erin Murphy. The primary endpoints of this study were specifically safety and effectiveness of the stent system, but we included a number of clinically relevant secondary endpoints to enable us to see how well venous stenting performs in treating patients with venous disease. The ABRE stent system is a self-expanding laser-cut nitinol stent. It's similar in design, therefore, to the Venogram stent, which again is an open-cell laser-cut stent, and differs from the Vici stent, which we'll mention later on, which is a closed-cell design. It is delivered on a triaxial catheter, which makes it very easy to deploy and gives it a very controlled deployment, and comes in a range of sizes and diameters, which are really helpful in treating the broad range of patients who present with venous disease. Baseline patient characteristics are fairly typical of a population we'd expect to see, predominantly female, a high percentage of patients with a previous history of venous thromboembolism at 52%, and the broad group of patients with disease were recruited in a post-thrombotic group, NIVL group, and acute DVT. It is important to note that these groups are all represented in the study, which is not the same as some of the other trials we've seen, which restricted certain patient groups. The majority of patients had their left limb treated, as we would expect with a venous disease. The most important point to draw our attention to in the procedural data is the number of patients who had stent extension into the common femoral vein, which is 44% of patients, and those were 88 out of the 200 patients recruited in the study. This indicates that the disease extension was quite significant in a number of these patients, and this is principally in those patients who were classified as post-thrombotic syndrome. The study met both its primary safety and primary effectiveness endpoint, beating the performance goal by some margin in both these categories. And importantly, 95.5% of patients completed the 12-month follow-up visit, which means the majority of patients were brought back in the study, which is a significant achievement of the recruiting centers. Major adverse events were very low, as we noted there, at only 2%, and the majority of these, 3 out of the 4, were in fact stent thromboses, which occurred within 30 days. No other significant events, which was not a long-term problem. If we look more closely at the patency data, although the primary safety or primary patency endpoint of 88% was met, freedom from clinically driven target lesion revascularization was higher at 92.4. And if we look at the individual breakdown of the subgroups we mentioned previously, as we would expect, the post-thrombotic group does worst at 79.8%, with a higher percentage of patency in the NIVL patients at 98 and acute DVT at 87. If we look more closely at the group extending to the common femoral vein, we can see that 78% of the patency was 78% in this group. And in fact, this was 64 out of the 67 patients with post-thrombotic syndrome, indicating that if you're calling patients post-thrombotic disease, you would expect to see extensive lesions and extensive disease treated. It is also worth noting that, as we mentioned previously, 51% or 104 of the patients in the study had previous history of DVT. Not all of these patients were classified as post-thrombotic syndrome if they merely had a NIVL lesion in the outflow tract. Device success was 100% with no problems in deployment or delivery of the ABRE stent system. And the secondary endpoints at 12 months, we see that the primary assisted patency was high at 91.8%. with secondary patency of 92.9, indicating that a number of the patients that had thrombosis of their stents early were recovered and patency was maintained at 1 year. Of significance in this patient population, we saw no stent fractures and no delayed stent migration. I think it is particularly important to note that with 44% of the patients having a stent under the inguinal ligament, this means we really can comment on stent fractures in this patient group. When we look at our secondary endpoints, which are the clinical driven outcome measures, we see a significant improvement in all measures between baseline and 6 months. And this improvement is then sustained after 12 months. Of particular note is the improvement in quality of life scores. When we look more closely at the Velocity score, you can see that the starting median Velocity of 11 improves to 4.9 at 12 months, indicating that the majority of patients went from being classified as having moderate post-thrombotic syndrome to having no post-thrombotic syndrome, which is obviously a significant outcome for the patient population with this disease. So in conclusion then, the ABRE stent system treated a challenging population, enrolling a high percentage of patients with stents below the inguinal ligament. Both the primary effectiveness and primary safety endpoints were met, with no problems in deploying the device and no stent fractures or delayed stent migration observed in the 12-month follow-up. In addition to this, sustained and statistically significant improvement in quality of life measures and venous functional assessment scores were seen at 12 months compared to baseline, and these patients will be continued to be followed up through 3 years to make sure that these improvements are sustained. When we compare this group of patients to the other IDE studies that have been published, we can look at the Venous study where there is a comparable distribution of patients in the baseline characteristics. In particular, the Venous study also included a high proportion of patients with stents crossing into the common femoral vein at 31.8%. And these, of course, were post-thrombotic patients in the majority of cases. The Venous study did not enroll acute DVT patients. The Venous study also met its primary patency endpoints, and the primary patency in the post-thrombotic syndrome group at 79.8% is pretty much identical to that seen in the ABRE study. But the major point to note between these two trials is the different performance of the closed versus open cell stents, where no stent fractures were observed in the ABRE trial, whereas we did see some fractures in the Venous study. The other comparison that would be drawn between open and closed cell stents is aspect ratio, which has been talked about quite widely, and we don't really have comparative data to see if that aspect ratio of the stent, the May-Thurner crossing point, will be significant over a long period of time. If we compare these studies to the Vernacular Study, the classification of patients was again different, with patients called post-thrombotic or NIVL, and we can see that the proportion of NIVL patients, the two, as we know from the previous data, we'd expect these patients to perform better and have higher overall patency. In addition to this, there were a number of patients included in the post-thrombotic group who in fact had presented with acute DVT, as this was allowed as per the study protocol. So while there is some overlap between the two, it's more difficult to directly compare these studies. Again, the Vernacular Study met its primary performance goal with patency rates of 89%, which is again very similar to the to the ABRE study, and again met its primary safety endpoint as well. The difference here again is if we're looking at the overall primary patency of Vernacular of 88%, we do need to compare the distribution of the two groups in this compared to ABRE. So how do we conclude from these studies? Well, all three studies have shown excellent results in the treatment of patients with venous disease, meeting their primary safety and patency endpoints, indicating that treating venous disease is both safe and efficacious, and patients do well. We have seen variables in how people have defined post-thrombotic syndrome, acute DVT, and NIVL, and it is important that going forward, these differences are sorted out so we can directly compare these studies. There are clear differences in the extent of disease treatment across the three groups, with the ABRE study arguably treating the most complex group of patients, with 44% of patients requiring stent extension into the common femoral vein. And the ligament is clearly a marker for disease severity and a significant test of the stent itself, and it is notable, therefore, that the ABRE had no stent fractures at this point. Overall, I think the conclusion is these studies indicate that stenting is here to stay. Treating patients with dedicated venous stent is feasible, safe, and durable, and we look forward to the longer-term outcomes from all these treatments. So at this point, I'll hand over to Erin Murphy from the Sanger Heart Institute in the Carolinas. Thank you, Erin.
I'm going to talk first about the technical properties of nitinol and why it has been targeted for use in venous stenting by all the new dedicated venous products coming out. So stent materials and stent designs perform differently in different environments. While there's certainly significant overlap in stent design characteristics that are needed for use in arterial, venous, and non-vascular spaces, there are also discrete differences that we want based on the location the stents will be implanted. So just because a stent is ideal in one location doesn't make it ideal in another. A focus on improving outcomes in the deep venous space has led to the development of venous-specific stents. In the EU, there's 7 dedicated venous stents with CE mark, and in the US, there's 4 dedicated stents in various phases of FDA approval or IDE trial. The 4 highlighted here in red are the ones that have CE mark as well as availability either currently or upcoming in the US. This is the Medtronic ABRE, the Bard Venovo, the Cook Silvervena, and the Boston Scientific Beachy stent. The wall stent also now has approval for a venous indication in the United States, although it is not a dedicated product originally intended for use in the biliary system. The Cook Z stent similarly is a tracheobronchial stent that is currently seeking approval in the US for a venous indication. The other remaining stents here, the sinus obliquus, sinus venous, and the blue flow, have CE mark in Europe with no current indication of coming to the United States. Before we talk about why nitinol is the ideal stent material, we need to know what it is that we need in a venous stent. So looking at the differences between arteries and veins, we can highlight the very characteristics that we want. Arterial disease is atherosclerotic, it's aneurysmal, versus venous disease, which is thrombotic and more compressive. So as opposed to the radial outward force that we're typically looking for in arterial stents, we need both radial resistive force as well as compression resistance in our venous stents predominantly. In addition, the stents tend to need to be bigger. This is a design challenge because as you take your stents to a bigger size, they tend to get weaker. So maintaining strength uniformly as these stents get bigger is very important. The stents must be more flexible than most of our arterial stents, even to the point of taking a larger diameter stent through the same turn in the pelvis requires more flexibility. And now you have our venous stents, which typically go into the groin and are subject to routine and repetitive axial loading, flexion, and extension forces. In addition, the patient's age comes into play. Often the patients are much younger in venous disease, and so we need long-term durability. And lastly, flow mechanics come into play. So the high flow in arterial system actually is somewhat protective against imperfections. When you have a low flow state in venous disease and you combine it with any residual disease above and below or below your stent or any imperfection in your technique, you have a vastly higher rate of stent occlusion. So you have a significant need for the ability to deliver a stent that is, you can land precisely and predictably every time. Okay, so how does nitinol help us? Nitinol has some properties that lend to exactly the characteristics that we just said we need. So this includes, in summary, the flexibility, endurance, precision, and strength. It is not a coincidence that all new stents are using nitinol as their material of choice. There are two characteristics of nitinol that make it ideal for venous stenting. The first is shape memory. So this is a response of materials to temperature, the ability for it to remember its shape at a certain temperature. This allows us to have a self-expanding stent because you can cool it, pack it into your sheath, and then when it's delivered, it expands to the size and shape that it's supposed to be. The superelasticity is more specific to our venous needs. This is the ability of a material to fully recover following repetitive large deformations or forces. So this is the stent not fracturing in response to repetitive axial loading, repetitive flexion extension forces, repetitive arterial beating on top of the vein stent. And the importance here, when we look at superelasticity in a little more detail or how it works, is that this is, can I start the slide over? This is different than what I sent. Margie, I'm just you can edit that part out. Hold on. So nitinol is one of the few alloys that can be super elastic at body temperature. The way that this works is it can change its crystal structure between two forms, austenite and martensite, in response to a load, and then back again when the load is removed. This, in theory, can limit lifetime displacement controlled fatigue of the stent so that it lasts beyond what an ordinary metal would without fracture. The other way to get this deformation recovery in a stent is to have braided stent designs. And this is how the wall stent, which is alloy or component of stainless steel, works, is that it has a braided stent design. The unfortunate side of the braiding design is you lose your accuracy and your precision, which we've already said is very important in venous stents. So having a metal that has those properties in itself allows us to now expand our stent design options. So it is not solely the nitinol, but the nitinol plus key stent design features that gives us those features that we want: flexibility, precision, durability, and strength. There's one additional component that should be mentioned. With nitinol specifically, when you change the tools, you change the rules, is a saying we've always heard. And it's not just material and stent design, it's also technique to maximally use your material. So there are three forces we talked about earlier between arterial and venous that we need to achieve: the chronic outward force, radial resistive force, as well as compression resistance. The chronic outward force is immediately apparent when you deploy your stent. This is the force of the stent always wanted to get to its nominal size. Unfortunately, that is the weakest strength component of a venous stent. What we really need in these stents are the other two components. So in our post-thrombotic vessels, our radial resistance, and in our nivel lesions, our compression resistance. That is achieved only when we balloon dilate our stents to nominal pressure. In that state, we are able to convert a good portion of the stent to its austenite state, which is 1.5 to 2 times stronger than it is in the other form. So it is essential to post-dilate our stents. So in summary, with proper technique, material, and stent design, we can hopefully achieve an ideal venous stent, and hopefully we are well on our way with the stents that are on or coming to the market. And I think that nitinol is an ideal choice to help us get there. We are also going to discuss and kind of turn topics here, the role of IVUS in venous stenting. So venography has been used for a long time now to image both our arterial system and the venous system. However, properties of the veins itself and as well as the presentation of venous disease makes this largely inadequate. The veins are oval, so depending on the gantry angle that you look, at your vessel, you're going to see grossly different images. In addition, you may see compression with widening in one plane, narrowing in another. The disease presents asymmetrically. The disease is multiplanar. It is multi-level. So you may see in one angle certain disease, but not the rest of it. Disease is often diffuse throughout the vessel. So there's no way to tell that if this is a normal vessel or not. There's no way to assess the area. So in general, I do use venograms, but what I use them for is to give me an overall idea of what I'm in for, an overall roadmap of the case. It's very good for assessing occlusions and level of disease, for assessing discrete lesions, for seeing collaterals, which can indicate an underlying obstruction, and for sometimes seeing things that give you a clue as to what's going on, like pancaking is akin to an underlying May-Thurner. Again, what it cannot tell you is that the vein next to it is normal. So even when you're looking at a discrete lesion, how do you know that this portion of the vein is normal? When you get a different gantry angle, this segment may look very similar to here. So you really need another way to fully assess the vessels. IVUS has become the gold standard for diagnosis. The diagnostic sensitivity is 90% or greater, and in my mind is considered mandatory for detection and classification of disease. And what we'll get into, it's probably equally or even more important to guide the remainder of your procedure beyond diagnosis. The video trial was a multi-center prospective trial, released data in 2016. It showed IVUS detected 88% more lesions than venography. And in fact, a third of venograms were normal despite IVUS positive disease requiring stenting. So venogram missed disease in a third of patients. This was supported by a couple smaller series. Raju and Neglin in 1993, so prior to video, showed the same thing, venographic sensitivity about 66%. So again, about a third appeared normal despite significant disease, and IVUS had a greater than 90% sensitivity in that paper. In 2016 as well, I released an abstract, venograms at our series missed disease in 25%, and in those where it did catch it, it still underestimated the degree of stenosis in 70%. So how do we use it? We look at IVUS and we, as far as area measurements of the vessels. So this is the best way to assess an asymmetric vessel. The areas that we use are 125 for the common femoral, 150 for the EIV, and 200 as normals. And we compare our areas to the anatomic normals. These correspond roughly to a diameter of 12, 14, and 16 in those corresponding vessels. This is the patient that I showed from the original, the first picture in the series of venograms I showed, and commented that how do you know the vein is normal? And this venogram in two different views, it doesn't show much going on here. And on this picture, maybe you have more of a discrete lesion, but it's not present in your other view. When you do your IVUS, there's an 85% May-Thurner that's not well identified. And the remaining portion of the vessels doesn't have any other discrete disease, despite what's alluded to here. There was a diffuse 50 to 60% stenosis without. So in the absence of IVUS in this patient, you may or may not have stented. And if you did stent, you may or may not have fully treated the proximal May-Thurner lesion or taken it low enough to have a good outcome for the patient and prevent stent occlusion. After disease detection, the IVUS is still useful to decide the rest of your decision-making. So the next step after I decide, yes, there's significant disease enough, I'm now going to use my IVUS. I'm going to determine my anatomic elements, the location of the iliac and femoral confluence, as well as the renal veins if I'm stenting into the cava. I then want to know my disease extent and the landing zones, because you have to land your stents in healthy portions of vein, both proximally and distally. The iliac confluence is often your cranial landing zone. You can move your IVUS up and down and easily identify exactly where the other iliac joins and then leaves as you're going up and down from the IVC into the iliac that you're treating and evaluating. Importantly, if you're just using Venogram, it can, because again of the gantry angle and the vessels lying on top of each other in certain views, your Venogram can differ from your IVUS detection of your confluence by a full vertebral body. Those of us who've gotten very good at finding it on Venogram can use certain techniques, including putting a catheter right at the confluence and changing your angle to find it. You can use bony landmarks, but IVUS is a very easy routine way to do this if you have the catheter available. So what's the consequence if you're not identifying the confluence correctly? And I see these complications referred to me in clinic. You can have contralateral DVT from jailing the other side. If your stent goes up too high into the cava, eventually it can function like a covered stent, as neointima basically excludes the other side. The stents can also erode if they're placed, and I think this may happen more often as we have stiffer stents, can erode through the wall of vessels if it's leaning against them at a wrong angle. If you land them too low, then you can have missed lesions, or in this case, the stent had watermelon seated back and eroded again through the vessel because of now the wrong angle for that stent to be sitting at. You need to stent to healthy veins, so sometimes you have to go into the IVC, so this you can stent to the infrarenal, suprarenal, or intrathoracic components. The most important thing is to find a healthy landing zone. Distally, you may very well have to cross inguinal ligament, and as Dr. Black was telling us, this is often the case in your post-thrombotic patients who have had a diffuse disease process and now have diffusely diseased veins. The most common cause of stent occlusion that I see routinely referred in our practice is distal untreated disease. This is a patient who had a stent placed, initially did well, went home, 2 weeks later came back in with a stent occlusion, and after lysis you can see where the remaining disease is. And this patient had the stent extended down and then had a great long-term outcome after proper landing zone. So how you select this, you want to find where your profunda is. The important thing about finding the profunda is you'll have a noticeable caliber change in the vessel as you're going through the common femoral. So if you're coming up from the femoral vein and the profunda comes on typically at the lesser trochanter, so you also have an anatomic bony landmark, and you'll see the caliber increase. When you're seeing the collaterals come on and off or the GSV come on and off, you typically do not have a large caliber change in the vessel. It is extremely important not to jail the profunda, so your landing zone is the best landing spot, or healthiest vessel segment above that. This is a patient who had their stent taken past the lesser trochanter, which is marked here, into the femoral vein. That was inadvertent, and that was not able, despite opening the stent several times and attempts at fenestration, that stent's not been able to be maintained. So be very careful about that error. After all your decisions, that is by far the longest part of my case, is making my decisions and where I'm going to land my stents and, you know, exactly getting everything lined up and planning. After that, the predilation, large non-component balloons to the intended size of your stents, stents that mimic normal anatomy, post-dilation, and then your final imaging, assuring you have no shelving, no thrombus, and good flow. So in conclusion, veins are elliptical, they behave and compress asymmetrically. Venograms are largely inaccurate for elliptical structures as they are a 2D imaging technique. IVUS, in my opinion, should be considered mandatory for diagnostic and interventional iliac vein procedures. And my steps are: determine the degree of disease, determine your anatomy, determine your best stent landing zones, and then your completion imaging. And I'm going to turn the next section over to my esteemed colleague, Dr. Desai.
Thanks, Erin. We've seen certainly vascular disease can be treated in a variety of settings, and that venous disease is really not any exception to that. That includes the office-based setting and the ambulatory surgical center. I'm going to say with the disclosure here that I work in an academic medical center, so I don't have practical working knowledge of working in these settings, but certainly it is a very common place to treat deep and superficial venous disease. And then inside the hospital, and I work inside of a quaternary medical center. So this is my predominant experience in how we take care of patients. There are significant differences, and we're going to start by examining referral pathways. I show this graphic here because having a successful office-based or ambulatory surgical center practice likely really depends on the relationships that you build in your community, instead of relying on a sort of in-place referral network within the hospital from inpatient consults. You need to practice with good word of mouth. You need to rely on referral from your providers. Advertisement is going to be a critical portion of what you do, going out and advertising the services you offer as well as your good outcomes. And there is certainly a potential for outpatient management of inpatient consults, but that requires you regularly being present in the hospital to do inpatient consults, so that then you can treat those patients in your office-based lab or ASC. Hospital-based practice I'm far more familiar with. This is the way I practice, and you have sort of a population that is captured. Certainly there are ED consults, and you can do ED consults that you can transfer to the OBL, although the pathway is probably a little bit less clear, as we'll discuss in a little bit. Certainly there are inpatient consults, and then there's also outpatient treatment. And I treat most of my deep venous patients on an outpatient basis, but there are trade-offs relative to a non-facility or OBL setting, which we'll discuss in a moment. Many outpatient services can really be performed in any setting. Treatment of non-thrombotic iliac vein lesions and compressions, pelvic vein embolizations can be treated in the office as well. And we can treat post-thrombotic occlusions, but we probably have to be somewhat selective about which ones we pick. Some interventions really are impractical or perhaps impossible to perform in an OBL, maybe not so in an ambulatory surgical center. Complex venous interventions that require anesthesia support, particularly those that are long segment iliocaval occlusions that require multiple accesses, may be impractical to perform in an OBL simply based on an economic standpoint. If you were doing a single case for several hours and then not billing for other cases, it may not make an office-based practice model viable. So certainly doing these longer segment occlusions that require a lot of support may be better to do within the facility. The referral pathway does differ within the facility. We do see our fair share of ER and acute care-based consults, certainly the acute DVTs. It's possible to do it in the office. I've heard of people doing that, but again, the pathway is a little bit less clear, whereas the patient is somewhat captive in the ED, and there's a built-in referral pathway that we can use. Acute liofemoral DVT is primarily what we see, but we certainly can see phlegmasia, pulmonary embolism, acute cable thrombosis. Here in the United States, we still have a lot of IVC filters that are placed, so seeing cable thrombosis in a filter-bearing cable is not entirely uncommon. And then in a cancer center, you may see malignant compression as well. But performing some of these procedures, particularly more simple procedures, may be less economically viable in the facility setting, simply due to the differences within the Medicare and Medicaid, the CMS fee structure. And that's where we may be able to leverage OBL efficiency. You can potentially treat deep and superficial disease concomitantly. We're in a non-facility setting, whereas treating superficial disease within the hospital may not be financially advantageous. And Dr. Kaleri and others can speak to that at length. There's also significant differences in turnover. Patient turnover in the hospital is notoriously slow. I'm sure my esteemed colleagues would agree with me. It could be much faster, and there are times that you want to grab the mop and the bucket to clean the room yourself so that you can get on with your day and to your next patient. Whereas in the office, I imagine that those efficiencies are much greater in terms of room turnover and seeing a number of patients in the same day. We're going to move on to a little bit about my practice and how we've built it here. We're at an academic medical center. There really is no dedicated office or ASC-based practice for any specialty, whether it's IR, interventional radiology, or for vascular surgery or for interventional cardiology. All of our procedures are done within the facility here. We do have superficial venous disease that is treated in our outpatient center, but it would not be possible to concomitantly treat those patients both for superficial and deep venous disease without taking some impact to your financial compensation there. And our care pathways are built through advertisement, but really with the large academic medical center, it's a lot of system, refer education, word of mouth, and social media. But really what I want to highlight, and I'll highlight this in a few slides, is that our deep venous practice is absolutely multidisciplinary. Why have a multidisciplinary practice? Really, the goal is to improve the quality of care that you can provide. That includes working with the hematologist, the cardiologist, interventional radiology, vascular surgery, if you're going to be dealing with a lot of pulmonary embolism, pulmonology, vascular medicine, and then, of course, with wound care, and you can provide holistic care for your patients. The deep venous practice at Northwestern specifically has IR performing the bulk of deep venous disease treatment. Certainly there were others, but now we perform the most of it. That's how it's sort of been built up as a legacy here. We've relied previously on referrals from other services, but really there's been a renewed effort to do direct-to-patient marketing and relationship building outside of our health system. And as I mentioned previously, superficial venous disease is seen collaboratively in a clinic staffed by both interventional radiology and vascular surgery. This is near and dear to my heart. I'm one of 3 or 4 actually 4 members of the Northwestern Venous Thromboembolism Clinic. This is a collaborative clinic that really, we got the idea based on what they do at children's hospitals, which is, for example, if you have a venous and lymphatic malformation clinic, it's possible for a pediatric patient to see multiple specialists exactly in one visit. And that's what we wanted to try and capture. The patients certainly love it. They can see multiple doctors at once. And then there is no communication breakdown between doctors that see each other, see the patient in different practice settings. And whereas in this practice setting, we'll see the patient and we talk about it and we come up with a collaborative plan. So not only do we have that collaboration and open communication, but we also have the ability to do cross-disciplinary research. And I've been amazed by the blind spots that I've had in my own research agenda that my pulmonology, hematology, and cardiology colleagues have pointed out. And I hope they would say the same with working with me. And it's led to some really good work that I'm proud of. So a proof of concept. This is just a brief case that highlights the VTE clinic that we have here. It was a 55-year-old male with a history of left lower extremity DVT and a submassive pulmonary embolism. A filter was placed at an outside hospital, and he underwent 48 hours of catheter-directed thrombolysis for pulmonary embolism. They showed no improvement, and he had a sudden onset of thrombocytopenia. He was diagnosed with heparin-induced thrombocytopenia, was switched from his anticoagulants were switched, and then he was discharged from the outside hospital. He transferred his care to Northwestern. Now he has severe bilateral extremity edema. He has venous claudication, and he is now O2 dependent at 4 liters at baseline on home O2. He was diagnosed via VQ scan and coronary angiography, right heart cath with chronic thromboembolic pulmonary hypertension, and we have a CTEF practice here. And so this patient needs to be cared for in multiple ways. And he was referred to me for evaluation of his leg swelling. So we perform imaging, and as you can see in these images here, there's a filter here and thrombosis of the vena cava. This, while it looks acute, is actually chronic. It's this expansile ball of collagen that's sitting in the infrarenal vena cava, extending into both iliac veins, as you see here. So we decided to proceed with cable reconstruction and filter retrieval to treat his venous claudication symptoms and his edema. But we were worried for a number of reasons. First, he has HIT, so managing the peri-procedural and intraprocedural anticoagulation needs to be done in close concert with our hematology colleagues. And not only, certainly we understand that we can use either argatroban or bivalirudin on the table, but how are we going to manage the transition to a subcutaneous or really an oral injectable oral agent in the post-procedure and outpatient setting? So those are all things that we wanted to coordinate before we do the procedure. And then we were also concerned that if we reestablish flow, that all of a sudden his right heart, which is of course sick because he has pulmonary hypertension from CTEF, might see this massive shift in cardiac preload and potentially cause a problem. So we made sure that not only do we have echocardiography, but we had our cardiology and pulmonology colleagues working close with us side by side in case that did occur. So in this, you can see in the image on the left here that the vena cava is occluded above the iliac vein here. This right iliac vein was also not in great shape, so we had to perform a little bit of acute pharmacomechanical thrombectomy, proceeded to a reconstruction after retrieving the filter, and we were able to perform a reconstruction of the infrarenal infravena cava into the iliac veins, and this was our final result. He then, in the immediate post-procedure period, prior to extubation, they were noticing that his oxygenation wasn't quite good enough. They thought that we had caused a PE, and I assured them that PE certainly wasn't going to be the main thing. He has CTEPH, and most of his clot was chronic, so it would not have been a large volume. And a CT was performed, and it showed what we were concerned about, which is that he had developed flash pulmonary edema from a sudden massive increase in preload to his right heart. So with my pulmonary and cardiology colleagues on board with us right there, we managed him successfully and rapidly with diuresis and PEEP with mechanical ventilation, and he was let go from the ICU about 2 to 3 days later, and he is now has been home, discharged, and symptom-free from his venous stasis. He subsequently underwent PT surgery about 1 year later after he was done recovering, and now he is not only symptom and edema-free from his lower extremity standpoint, he is now no longer O2 dependent. So in conclusion, patient pathways in deep venous disease really do differ by care settings. Between the OBL and the ASC versus the hospital, there are possibilities where you can adapt to best take advantage of your practice setting. Really, I don't think there's one size fits all for this. You just need to understand what will work in your particular situation and what may not. There's also potential for synergy in taking the best of both. Quick procedures might be best performed in an OBL to maximize efficiency, but if you're expecting a particular procedure after workup, before you perform the procedure to be particularly complex, you may want to do that within a facility to leverage not only greater availability of support staff, but then not compromise the economic viability of your OBL. And finally, what I really want to drive home is that multidisciplinary collaboration is absolutely critical to good venous and really all care, but since we're talking about venous care, I think it's critical to good venous care. It's crucial for good outcomes, and it helps foster high quality cutting edge research. So with that, I think we're going to move on to a panel discussion. And I can start it up. What is the flow of patients through your center? How has it worked in Carolina?
Yeah, so I think it's changed over time. There wasn't a big deep venous practice when I first got here. So I think we initially set out targeting wound centers that were already working with us from an arterial standpoint, and then discussed with ER as far as acute DVT. Over time, based on shared patients with cardiology, pulmonary, and particularly hematology, we've been able to kind of educate each other and expand each other's practice. I think particularly with hematology, who had not a big sense that there was something could be done for all of their chronic patients, has been a big relationship building and a big source of patients for us.
Excellent. Steve, how about you?
Yeah, I mean, I was similar in many respects to what Erin describes when I started building a deep venous practice in the UK. I think we were fighting years of entrenched belief that treating venous patients was doomed to failure, and there was no point in doing it. And actually, it's been gratifying, I think even quite quickly in the last 5 years, to see that attitude changing. I think the stent results we've seen from all the trials, these are good results. And when you compare them to PAD and the patency of stents or reintervention rates in PAD, it's way better in veins if you do things right. So I think, we've seen that change, and that's helped. But in my practice, it's been exactly the same experience that Erin describes. We went after building relationships with hematology, building relationships with the ulcer clinic, which I'm fortunate to run in our hospital with my other vascular colleagues. We do our own wound care. We don't have specific wound care centers, so we can get the patients more easily. And I completely echo what Kush said about building a team. These patients are complicated. They have multiple problems. They've had, even if they're chronic patients, they may have had PEs in the past. You need to have a pulmonologist involved. The hematology is hugely complicated. I've learned an enormous amount from just spending time with my hematology colleagues and my pulmonologists, listening to them, because you start to appreciate the subtleties of this patient population much more effectively. And that's knocked on to just treating chronic venous disease in general, to the points you've made in the past, Riku, about pulmonary hypertension causing leg ulcers, for example. You start to pick those things up. Yeah.
Cool. So ours at Riverside Methodist Hospital, I guess, the two doors that the patients enter through. One is the ER for the acute DVTs and the pulmonary emboli. Our cath lab is right on top of the emergency room, so it works out really good. And slightly unique at our place is on the single floor, about 2 floors above the cath lab, is the wound center, and within the wound center is the vein center, and right next to the wound center is the heart failure center. So it's really, we talk about collaboration. We have podiatry colleagues, we have the heart failure colleagues, and vascular medicine, interventional cardiology, and vascular surgery provide most of the care in our clinic. So, the most common question, let me ask the panel, what your pathways. Okay, patient, let's take the acute DVT out. We know that, someone comes with a massive leg, because most oftentimes the pathway is more clear. In the chronic patients, if a patient comes in with, symptoms of post-traumatic syndrome or symptoms of chronic venous disease, you see the patient, you get a history, maybe the patient has history of DVT, maybe the patient does not have history of DVT. What happens to the patients in your center? Would they go to the CT? Would they go to the vascular lab? What are your pathways? Let's, just because that's the most common question that, I get asked.
Yeah. I'll say that when I started, and before I started doing deep venous disease here at Northwestern, a lot of what it was, say somebody came through the ED, and if the duplex said chronic, it was ignored because it's not acute and I don't have to worry about the PE. And it took education on my behalf to go and say, well, okay, yes, you don't have the item that potentially could kill the patient here now, but you have something that is potentially a huge impact on their quality of life, one, and then two, the impact that it has on, their productivity, their ability to work, all that is sort of being ignored. So you are frequently the first person to touch that patient. So it took education with them. Then I went to the general medicine colleagues, and then our hematologist, as Aaron and both Aaron and Steve mentioned, and I had the same talk with them and says, these are patients that there are options for now. And then you take that burden off of them, because it's repeated visits with them. It's just over and over and over again. And they're just like, well, I'm telling you, it's compression. Yeah. So that's been a big part of what we do. Now, in terms of the imaging bit, which was your main question, what we end up doing is if they get an imaging from the ED, then we see what they've gotten and then decide the next step. It's frequently in our center, we don't have the ability to do iliac and IVC duplex super well. I know this is a frequent topic of conversation on these talks that we do, but so we do a lot of CT venography. We also do dual energy CT venography, and we found that we can leverage dual energy with iodine maps to learn quite a bit, and hopefully we'll have some publications there. And then if they've come from externally or from an outpatient center, we see what's been done, because frankly, as I think Steve mentioned just now, these patients are hugely complex, and it's really hard to go through an American healthcare system without getting a CT scan.
That's right.
It's really hard. So frequently something's been done, and then I can kind of just cobble together a picture, and then sometimes people don't even need imaging after that.
Excellent. So anyone use venous insufficiency physiologic test as the first, piece of information in these patients presenting with chronic venous disease? Steve, what do you think?
What physiological test do you mean? Very good.
Anything. I mean, whether it is duplex to
That's-
assess the
yeah.
reflux pathways or, APG.
Okay. Yeah, fine. So I'd say duplex to assess reflux is mandatory if you call that a physiological test. So I think that's an imaging study to some extent, and that fits with everything else. You have to have good duplex below the leg, and a lot of it has required engagement with the duplex labs to start thinking differently, because there's the history of all of this is nobody looked above the groin.
Yes.
And big Cushing's point, if it was chronic disease, you got stockings, and that was it. And there's also a slight, I think, historical fallacy about venous disease, that it was where you sent your rubbish arterial surgeons so they couldn't cause any problems. And, I think thankfully it started to change. And the irony is it's probably a hell of a lot harder to do venous disease than it is to do arterial surgery. So, that's part of the problem. So once you change that mindset, you get good duplex, you start to get people to look above the groin when they do the duplex, and then refer the patients on. And part of that was also getting the physician-based colleagues in hematology. The drive for DVT was always recurrence and prevention of PE. Nobody was looking at the leg or thinking about it, because even in all the big comparative studies of warfarin and DOACs and so on, historically didn't even report outcomes for post-thrombotic syndrome. They weren't even looking for it at a year. They were looking for recurrence and PE as the outcome measures and bleeding risk. So once you change that, you get people doing well. So duplex, we definitely do. Air plethysmography, but it's so hard to do properly, and the reproducibility of that has been poor. Outside of those enthusiasts who really get good results, it's very, very difficult to get outcomes that make sense. There are some things that probably show a little bit of promise. One of my research fellows, Rachel Morris, has been doing some work on venous return to the heart and people with extensive IVC occlusion. And one of the devices we started using to look at that is a cheetah device, which is a very simple thing where you do a straight leg race and you look at changes in venous return. And we started to see differences even in patients with a single leg iliac vein lesion. There's no data to back it up yet. It's dead simple to do. And if that shows promise, maybe we have something else. But at the moment, I don't have a physiological test that I think is reliable enough to use.
What about you, Aaron?
So my pathway, if it's CEAP2, is a reflux DVT in isolation. CEAP3 and higher gets always an assessment of superficial and valves with a reflux DVT scan, but also some imaging of above, so that I can weigh what the likelihood of their improvement with various interventions might be if they have one, both, or neither. Patients who present with bilateral edema, I still get a lot of. I started screening them with CT and reflux. If they have a history of DVT, I also get an iliac scan so I can better assess in the vessel with webbing and stent landings if I really think they're going to be a stent candidate. That's my pathway. We actually bring the patients in with those testing if their insurance allows, to limit the number of visits they have to get their workup complete.
Interesting. It's interesting how the patterns differ. What we do is, like Kush said, almost all of my patients first get the CT scan and then go to the ED to registration in the United States, right? So they all have some sort of axial imaging. So we start with a reflux test, and we look at the deep venous reflux, superficial venous reflux. We look at the superficial epigastric vein reversal. We'll look at iliac veins on duplex itself. And, if I can't put a number, but 50-50, probably we go straight with that information to IVUS and Venogram, unless there is, prior occluded IVC, or there's a reconstruction needed, or more complexity is involved, or if the duplex showed a mass or what have you. So it's kind of interesting that how the patterns are different. Ultimately, I guess the patient ends up getting the proper treatment, whichever way they go.
Well, not so different though, Raghu, if you think about it. I mean, it's just the order, isn't it? So all of us are doing a
That's
duplex.
what I'm saying. Yeah.
The leg. All of us are doing axial imaging, and I think that's important. And that's a big step for people, is to go, if you've got a history of DVT and you think there's deep disease, look up get some other imaging of the iliac and cable system, and that can't, I think Duplex and axial imaging and MR, CT are complementary, and then IVUS and Venogram is your final stop to be sure to what you're treating. And we only use IVUS and Venogram if there's uncertainty. If there's not, then they happen at the same time as intervention. So you try and save that. I mean, obviously we're in a public health system where nobody's paying for anything.
Right.
But COVID has wrecked us now, so we're going to have a lot more restrictions.
Thank you all for joining us for the program today. It was fun to receive your CE credit for the topic. Please complete the evaluation located in the right-hand navigation bar. You'll then be able to download or print your certificate. Thank you very much. Thank you all for joining.